Dr. Ben. I'm a pediatrician here in Savannah. Let me tell you who I am and who I'm not. I'm a general pediatrician. I'm with Pediatric Associates of Savannah. I am author of a AAP parenting book, Baby Care Anywhere, available on Amazon.com and other places. I've been a member of LDSS since it started. I'm a big supporter of NDSS, National Down Syndrome Society, which is an advocacy group. I follow DSMIG, which is the Down Syndrome Medical Interest Group, which is where medical professionals keep up to date on discussions and newer things. What I'm not is I'm not a Down syndrome specialist. Down syndrome is a complicated collection of many different items that covers many subspecialists. And the point of today is to tell you that if you want good care for your child who has Down syndrome, any good board-certified general pediatrician can do it, as long as you are also an advocate for your child. So, Austin, would you help me, sir?
Yeah.
What I'm here today for is a conversation. Would you make sure every table gets about 3 or 4 of those, please?
Yes, sir.
Thank you, sir. Is for a conversation about the care of a child with Down syndrome from a pediatrician standpoint. And where's the camera? LDSS. If you are not here, you're missing out on the conversation. So this is open, this is discussion, this is not just talking, this is conversing. We have parents here of older children that have been through this. We have parents here of younger children that are just going through it. So if you're not here, you're missing out. So this is for conversation. At any point, please stop me and ask questions if there's something we need to learn more about. So I've been doing this for almost 20 years, and you guys are really in sort of the golden age of caring for a child with Down syndrome. In just the last decade, so much has been studied, published, and formalized. When I first started doing this, there were guidelines on how to take care of your child with Down syndrome. Oh, as you're getting this, pull out your readers. This is very small print. I know some of you guys are pulling out your readers. The young ones over here don't need to, but I know I wanted to fit it on one page. So when I started doing this, there were guidelines for the pediatrician, and they were a little bit anecdotal. They were a little bit systematic, but they weren't based on necessarily up-to-date data. So pediatricians did it a bunch of different ways. Do you get everybody, Austin?
Yeah.
Thank you, my friend. Oh, what? We missed a few. Don't miss Grandma Alice. So don't get too lost in that yet. Get Grandma Alice?
Oh, darn it. You're doing those.
All right. So, thank you. Oh, I love you.
Thanks, man.
Thank you, Doc. So, any generalized pediatrician can take care of your child with Down syndrome. Before your child is a child with Down syndrome, your child is a child. Yeah. That's more important than anything. A pediatrician who is board certified, who follows with the AAP, has a Bible for how to take care of a child of all types. It's called Bright Futures. Bright Futures is our pediatrician guide of how to do checkups for the 1-month-old, for the 6-month-old, for the 10-year-old, everything that needs to happen in terms of what labs do you do, what tests do you do, what sort of things that you do. So for starters, like 95% of taking care of a child with Down syndrome is taking care of a child. It's all very important that you don't become the child with Down syndrome and not the child, because then all of a sudden you start getting things missed, your lead level or your other things that are immunizations, your things that are very important. So any pediatrician takes care of your child will first follow Bright Futures. But then 2011, the AAP put together their most recent guidelines, and these are the new guidelines. I know 2011 seems like a long time ago, but this is the new guidelines. In 2011, they put out their guidelines on what else a pediatrician should do to take care of a child with Down syndrome. If you would like the full 16-page version, I brought a few copies of that. It's also available online. If you basically Google AAP Down syndrome guidelines, this is what you get. But I will leave a few here afterwards if nobody else wants them. But the real kicker is on around page 14 is what you just were handed by Austin. This is the health supervision checklist or guidelines of things that a pediatrician should also do for your child with Down syndrome. So this is, again, a conversation. And what I was hoping to do today was go through some of this and talk about some of what's in it and some of what's not in it. Some of you who have kids that I've been taking care of for 13, 14 years, there's things that are not in here that I used to do that we don't do anymore. So I'm going to sort of go through this a little bit systematically, but at any point, stop me, ask questions, talk about whatever. All right. So the first few things are done usually in the OB office or in the delivery NICU, and this has to do with planning, physical exam, lab test to confirm, trisomy 21, that sort of thing. Echocardiogram. This is important, and all babies at birth will be seen by a pediatric cardiologist, if not before birth. About a 50% chance of a child with Down syndrome having a heart defect. It's called an endocardial cushion defect, which is a collection of different holes that can happen along with Down syndrome. It's the genetics of it. So everybody gets seen by a cardiologist. If you don't know if you did, you probably did. If you were born in a hospital, a cardiologist, and your child had a diagnosis of Down syndrome, important. If your child left the hospital without the diagnosis of Down syndrome and it came later, they will need it. Now, every pediatrician, as I said, can handle taking care of a child with Down syndrome. Not everybody follows as closely as they should. Pediatricians, doctors in general, I'm one, we're very proud. We don't always take to our patients telling us what to do. So there's a way to do it. If you hand them the 16-page handout and say, here's what you need to do for my child, they'll say, okay, those are those crazy parents trying to tell me how to do my job. But if you have the one-page checklist and say, now, we've been following the AAP checklist for our child. You say AAP, they'll realize, oh yeah, I got to do it. And you can leave it with them and they will realize, yes, here's what needs to be done. This is a great way to keep up. And some pediatricians have memorized by now, but if not, this is a great way to do it. So we're down to echocardiogram. Eye exam for cataracts. There are a lot of eye issues in a child with Down syndrome. It's important that they get seen by the pediatrician. They'll do what's called a red reflex examination, basically where they look through the eye scope and look in the eyes. And then we as pediatricians usually do what's called a visual ocular screener. It's a little machine. Ours tweets, and then they look in it, it looks for things. And then, as you go down, you'll see eyes a few times on this checklist. Your child should see a pediatric ophthalmologist. Now, once you get to the ophthalmologist may not follow this guidelines of how often. They may see you more often, they may see you less often, depending on what they see. But at some point, early on, your child should see a pediatric ophthalmologist. Delayed dental eruption, this is nothing to be worried about. I want to get to a few other things. CBC, to rule out transient myeloproliferative disorder. Basically, children with Down syndrome have a slightly higher risk of leukemias and cancers. They should get a CBC. You follow in here, birth to 1 month old. It's probably going to be done in the neonatal ICU. It's probably going to be done in the hospital before your child even goes home. If not, it'll be done later. Thyroid screening. So your thyroid is an organ in your neck that controls your metabolism. It makes a hormone called thyroid hormone, T4. Am I okay behind the podium? I feel awkward, like I'm not with you guys. I feel like I'm hiding. So your thyroid makes your hormone called thyroid hormone. It's called T4. And if it's not doing a good enough job, your thyroid stimulating hormone, your TSH, will go up. Part of the newborn metabolic screen in, I believe, every state, certainly in Georgia, is to check your TSH and T4. But on top of that, even if that's normal, your pediatrician should follow your child's thyroid, whether they do a TSH and a free T4 or even just a TSH, frequently at birth. And then as you see down the list, it pops up many times over. Something that, it'll come down here, but I want to get to this. Growth charts. So growth charts are very important. When I first came out, there was Down syndrome growth charts, there's still a website out there called DS Growth Charts. It's not the most accurate. So growth charts are basically data that's been collected over a long time, showing you on average how big people are of a certain age, newborns, 2-year-olds, whatever. And there are several different growth charts out there. All pediatricians use growth charts to track your child's growth. I know, it's crazy. For a child without Down syndrome, they use usually the CDC growth charts for kids over age 2, and the WHO, the World Health Organization growth charts for children, for infants, for babies up to age 2. There are also specific Down syndrome growth charts that are available on the CDC website. And they're for birth to age 2, and they're for over age 2, 3. And they're separated by gender, boy, girl. Here's what's important. It's important that your pediatrician follows your baby's growth, your child's growth, on a growth chart. It almost doesn't matter whether they're using, and I hate to say this because my preference is Down syndrome growth charts, but I don't always use them. But it's important they use some growth charts, whether it's the standardized, not normal, there's nothing we say that's normal, standardized growth charts or the Down syndrome. It's important they use one or the other, and here's why. So I don't have a blackboard, but a growth chart will look something like this. It'll be a graph, and you'll have X and Y axis. Here's how old your child is. Here's how tall your child is. And your growth should be something like this, okay? Even better. Look at you to my rescue. So let's just say, and I'm totally making up numbers, that for a boy, the standardized growth chart, your height curve is like this. And for the Down syndrome child, your height curve is something like this. All right, genetically speaking, a child with Down syndrome is going to be frequently less tall than a child without Down syndrome, but not always the case. Regardless, what you'll see is the trend is very similar. So whether they're saying you're below average for the standard growth chart or above average for the Down syndrome growth chart, I know we like to compare with everything. We like to compare our children and say, oh, we're 85th percentile. I feel very proud of that. That's okay. But what matters is your child following a trend? So if anyone says, the growth charts really don't matter for your child because we don't know how big your child is supposed to be, we don't, but we do know that they're supposed to grow at a certain rate. And what growth charts tell a pediatrician is your child growing at the right rate? There's a lot of reasons why they don't. And with a child with Down syndrome, it could be a thyroid issue, it could be a digestive issue, it could be many other things. So if you see a child on either chart whose height is doing this, you know something's wrong. Or whose weight is doing this, you know something's wrong. So it's important that your child is plotted on a growth chart. And if you want to do it at home, you can. Growth charts are available. Go to CDC, just Google CDC growth charts, and you'll find it. Google Down syndrome growth charts, but make sure you use the CDC ones, and you'll find it. Or standardized growth charts, whichever ones you want to use. But it's important that your pediatrician is tracking your child's growth, not just to see how tall or how heavy they are compared to other kids, but to make sure they're growing at the right rate. Did I just beat that into the ground? So that's important.
If you want to do it yourself.
If you want to do it yourself, you can.
You do that, you just...
and then you tell you... Well, or you could just take, when you go to your checkups, they'll give you usually your height and weight, and you can go home and do it yourself.
Or your doctor may have an online portal.
Or your doctor may have an online portal that gives you that information. Sure. But regardless, it's important. And your pediatrician, I'm sure, is tracking, but just always make sure. And then you come back and say, I'm worried. It looks like we're not following the curve. That's a red flag to a pediatrician if you're not following the growth curve. I'm going to get to a few other things on here. Discuss cervical spine positioning. So this is kind of controversial. So for a pediatrician, for any doctor, here's what's accepted and here's what's new. It's accepted if I learned about it in medical school and residency. It's new if it came out afterwards. Pediatricians are supposed to stay up to date. We do what's called CME. We get continuous education, so we're always up to date. But we can't continuously learn about everything there is. We will never keep up with everything. So in general, doctors, pediatricians tend to grasp what they learn in med school and residency. C-spine. So a child with Down syndrome has a higher risk of something called atlantoaxial instability. Your spine, your vertebra, are really cool. They're basically interlocking pegs and discs that go kind of like this, okay? The very top one, which is called C1, C2, at the base of your neck, has a much more potentially fragile little peg right here, and it's at the base of the skull. If it's fragile, your neck potentially could weaken to cause a spinal injury, and that's called atlantoaxial instability. When I trained, every child, 2.5 to 3, had to get C-spine flexion extension films. That was the x-rays. People are nodding their heads. I did them for a decade. C-spine films to check to see if there was movement in the neck. And I got the whole article for you. New data suggests it's kind of useless. So they say, first of all, doing it under age 3 really doesn't give you very good data because not enough is bona fide, ossified to really show you if there's movement. And then even after age 3, the films may not be a good predictor. So the AAP does not any longer recommend systematic, everybody getting C-spine films. So do we still do it? A lot of us still do. A lot of you, when you get your forms for physical therapy, for horse camp, for many other participations, still have the box that you have to check and say, did they get their C-spine films? Without, you can't participate. So yes, some orthopedists not only recommend them, they recommend them twice. I know some pediatric orthopedists that recommend them at 3 and then at age 6. So here's the answer to that. It's better to err, I guess, in the way of doing more rather than doing less, but C-spine films are no longer a standard recommendation, a standard requirement of a child with Down syndrome. I've really stopped doing them as much in the last 2 or 3 years. When the 2011 guidelines came out, I still grasped it for a little while. And obviously, if you have a therapy form or a participation form that requires the films, we do the films, but they're not as important as we used to think they were.
What about treatment if there's an issue identified?
So the treatment, exactly right, is watch and wait and hope and possibly limit physical activity so there's not potentially a traumatic event on the neck, but you don't put them in a brace. You don't do anything special other than limit activity. So that's part of why it's not done as much, because the films weren't that accurate and there wasn't really anything necessarily you would do after. So exactly. What is, however, more important that didn't used to be, I'm skipping down just a little bit, is a sleep study. Sleep apnea was formerly, was formerly a less appreciated, I don't want to say recognized, but less appreciated condition of everybody, let alone a child with Down syndrome. Sleep apnea, if you have it or if you have a family member that has it, it's a real thing, and it will, when you don't get a good night's sleep, it affects every aspect of your attitude, of your learning, of your health. And what they've recognized is that a child with Down syndrome has a much higher risk of sleep apnea. So now the recommendation is all children by age 4, we usually send them at their 3-year-old checkup, get a sleep study, and that's done usually in a hospital, usually by either an ENT or a pulmonologist. And it's an important thing to do. A child with recognized sleep apnea may need ENT evaluation or other therapies to help them get a good night's sleep. But good night's sleep is important. So that was not in the old guidelines, but now every child around age 3 gets a sleep study. Audiology. We do audiology, we do hearing assessments in the hospital. By 6 months old, every child should have their hearing checked. And that's important. You don't want to miss the critical age of babbling and learning how to talk. And if you wait until they're 4 years old and doing the tones and raising their hands, you've missed a significant issue. And a lot of speech delay is not, oh, your child has Down syndrome, they're just not learning fast enough. It's actually being able to hear the correct tones. So audiology is also very important. Ophthalmology, celiac. So celiac disease is a digestive disorder, And here's the thing. It can present as a lot of different signs, whether it be changes in poop, changes in growth, changes in appetite, which pretty much any child with Down syndrome is going to have. I don't want to say pretty much, but pretty much. A lot of pediatricians will do a celiac screen, blood work, to check for celiac disease. And it's saying here 1 to 5. Usually we do it at around the 3-year-old checkup. But a celiac panel is blood sent off to a big lab where they check for immunoglobulins, which screens for celiac disease. It's pretty important. Celiac disease undiagnosed can become, oh, he's a picky eater. Oh, he's just not growing. Oh, she just has poop issues, that sort of thing. So it's important to diagnose there's a high enough risk in the child with Down syndrome. Celiac, C-E-L-I-A-C, and it is about 2/3. This print is small. I know it's small. It's about 2/3 down and says check for symptoms of celiac disease, and it says if symptoms present, obtain tissue, transglutaminase, IgA, quantitative IgG. So most of us do blood tests. ADD. This one is coming in the 5 to 13-year-old range, but discuss self-help skills, ADHD, OCD, wandering off transition to middle school. So this is hard. So a lot of our children with Down syndrome have learning disabilities. And as a result, I don't want to say lower expectations, but we're less likely to recognize other comorbid, other learning issues like ADHD. And for a non-Down syndrome child, it's pretty easy to get a psychologist to do some testing and find out here's where your IQ is, here's where your learning is, here's where your attention span is. In a child with Down syndrome, is very difficult. So we don't often get to use the typical testing mechanisms or the typical Vanderbilt questionnaires or the forms we fill out. Sometimes we have to call like we see it and try to treat it and see if it helps. And sometimes it does. But if your child is having issues with attention and impulsivity and learning in the classroom and outside the classroom, don't let someone say he just has Down syndrome and he has trouble learning. Do think about there could be other factors involved. That's important. I skipped over, I talked about growth charts, but I want to talk about growth. So another issue with children with Down syndrome is obesity. Children and young adults with Down syndrome. And genetically, there may be a predisposition to different body shape. It's genetics is what it is. On the other hand, sometimes a family with a child with Down syndrome has different expectations for their child. A child without Down syndrome is expected to play volleyball in the fall and soccer in the spring and do summer workouts at their school. And so often there's the expectation to be continuously physically active. And our child with Down syndrome, who may not be into competitive sports, there's less of a push to keep them physically active. Anyway, point being, don't assume that obesity is a genetic necessity. Push them to exercise, push them to participate, push them to have a good diet, push them to do everything you would expect of any child, so that way they practice not just healthy habits, but when you look at the growth charts, there's the standard growth chart, not normal, and the Down syndrome growth chart, and some of that is genetics, and some of that is medical issues, and some of that is expectations. So what these charts are not what a child with Down syndrome should weigh. It's what the average child with Down syndrome does weigh. The data is made up of points of all the kids out there and what our average is. And maybe some of that's the reality of genetics, and maybe some of that is our expectations and that's why we've abandoned the old Down syndrome growth charts, because those really were skewed off from others because they didn't take into effect the issues with thyroid disease that weren't being recognized in others. Everybody's waving their cards. It's hot in here. I thought it was just me up here. Guardianship, financial planning, behavioral problems. This is to the camera. If you're not coming to LDSS meetings, you are missing out. There are things beyond what your pediatrician is going to tell you about how to prepare for your child's future. Your child will need financial stability. Your child will need, I'm gonna wrap up, no questions. Your child needs not just financial stability, but needs a stable future. You will not be here forever to take care of your child. Your child will be here for a very long time. A child with Down syndrome who's taken care of, come here, Kalia, will grow into their 40s, 50s, 60s, and beyond. You need to be prepared for that reality, and don't just assume another family member will step in when I'm gone. You need to have a trust. You need to have that kind of planning ready. And a group like this, the LDSS, when we do these meetings, this is the boring one. The other meetings talk about things like how to prepare for your child's future and how to set up an estate and how to be an advocate for your child. Come to these meetings. Was that good?
That was great.
Come. I mean, there's so much that you don't think about now. You may be thinking about, is my child getting the best physical therapist? Is my child's school providing enough inclusion? That is important, and we talk about that here too, but we also talk about things you haven't thought about yet. How do we get a job one day? I mean, the goal isn't to graduate high school. The goal is to have a successful, productive, meaningful future, and you can't do that on an island. You come to a group like this, and you will see children and adults of the whole spectrum of life and find out how one leads to the next. That's important. I've overdone my time. I'm going to be quiet for a second. Any questions about medical care of a child with Down syndrome, medical issues, medical anything, or non-medical?
How might you recognize sleep apnea before a sleep study?
Okay. Snoring, restless night sleep, groggy during the day, cranky during the day, and those are probably the best ones.
And
a sleep study can be done earlier. We usually recommend one by age 4. Most of us at age 3 set it up just because by then the tonsils, adenoids, whatever, if they need to come out, they're big enough for that to happen. But it can be done sooner if there's an issue sooner. Absolutely. Yes.
Can I add something to that?
Yeah, anything you want.
She's been diagnosed with sleep apnea.
Okay.
But she won't keep the probes in her nose.
Yeah.
Or the mask on.
Yeah.
And she sits up.
Yes.
Throughout the night, even still.
She probably sits up to relieve the symptoms of sleep apnea. And the short answer is, without making this sound easy, is continue to work with, I assume it's an ENT that you're working with, continue to work with either your ENT or your pulmonologist, because if the issue's, yes, beautiful, if the issue's not fixed, continue to be your child's advocate and find out what the next thing is, what the next option is, what the next best thing is, because there's always something better you can do. Yeah, she sleeps up, she wakes up a bunch during the night, I bet you she snores all night long. And I mean, without a good night's sleep, it'll affect your growth, it'll affect your learning, it'll affect your behavior, it'll affect a lot of things.
And so can children with Down syndrome also be autistic-like?
So the answer is yes, and yet it's very hard to draw the line between genetically expected intelligence issues and autism, which is a communication disorder. The answer is yes, your child with Down syndrome can have autism. It's often very hard to separate the two from each other. And a lot of times we will involve what's called a developmental pediatrician, or developmentalist is what they're called. There's a couple here in town.
We're going through that now.
You're going through that now. Because sometimes it's hard to separate them, and what you end up doing is trying therapies for everything to see what you can do. Whether it's ABA, which is behavioral therapy, or others. Yes, a child with Down syndrome, and that's you just hit it. People will say, oh, she just has Down syndrome. No. Yes, your child has Down syndrome, but you also will have potentially ADD, autism, other issues that need to be addressed, and not just assume the expectations are lower because of autism. Because of Down syndrome, you've got to be your child's advocate and continue to work on everything. That's a great point.
With her ears and everything, she's had ear surgery.
Sure.
Tubes twice, and then surgically cleaned.
Mm-hmm.
And because she couldn't hear for so long, she now has a PRC device.
Yeah.
And so now the discussion has been brought up. Let's get her out to Statesboro and see if there's some trace of autism.
Sure. And the Statesboro Developmental Pediatrician, she's very good.
Okay.
She's very good. Yes.
Should a parent still be on the lookout for sleep apnea even after tonsils are removed?
Oh, absolutely. Just because tonsils come out does not mean sleep apnea is cured. Further sleep studies could still be an issue. So tonsils are what you see when you look in the throat. Adenoids they're your tonsils' best friend. They're like your tonsils, but they're further up and behind. You, the pediatrician, can't see them. An ENT can. Sometimes x-rays can. So sometimes tonsils without adenoids coming out, the adenoids could still be the issue, or there could be other airway issues. So yeah, just because your tonsils came out does not mean sleep apnea is necessarily over. Very good point.
Yeah, because he had him on.
Yeah.
And I wonder why he kept sitting up and sit all the time.
Yeah.
And he sits right up.
Yeah.
He sounds asleep when he's doing this.
Yeah.
Your adenoids removed twice, and you still have sleep apnea.
Yeah. Try to get him to sit on there.
Emily, from time to time we get emails from groups conducting medical studies, and they're looking for people with Down syndrome
Sure.
to participate. And I don't know, are there any tips for
Make sure whoever's doing the studies are legitimate, and that's always hard to tell. But let's put it this way. You don't want your child to be experimented on. However, it takes willing participants now to learn more, just like we have people that went before us that can tell us about Kalia. It's good to participate in medical knowledge. So that if you don't know if something's legit, talk to your pediatrician. They can usually weed out what's the real stuff and what's the wacko stuff.
is there anything local that you know?
Not related to Down syndrome. I know there are a lot of local medical studies that take place. I know some of those groups. I don't know of any right now related to Down syndrome, but it's not a bad idea. Good question.
We had a graduate student here, Anne, remember last year or 2 years ago, she was working with Dr. Galvin Colquitt over at Georgia Southern, and she did some testing for physical fitness in childhood obesity with children with Down syndrome. So we participated in one of her studies on that.
Cool.
So that's another thing that if you're interested in, we can reach out and we'll bring Dr. Galvin back to talk about health, and things of that nature.
All right. Yes.
How do parents know about these studies? Is it something that's fed through the pediatrician?
So they can be, not always. Usually pediatricians were bottom feeders. Usually good studies come through the subspecialists, through the allergists, through the ENTs, through the others. And if your child has Down syndrome, you're probably seeing many subspecialists. Pediatricians, we don't get as approached as subspecialists do. Why? Who funds research is usually companies making cool, expensive things, and pediatricians, we don't get the cool, expensive things, but a lot of subspecialists do. So, yeah, ask your ENT, ophthalmologist, cardiologist, gastroenterologist, neurologist, you're seeing them all, and they may know of something. Yes.
Ben, you had checked Ella for AAI when she was about 4, and that was really before. She was doing like dance classes, and I think that was about it.
Sure.
But now with horseback, karate, full on cheerleading,
sure,
that you actually have more physical contact.
Yes.
We have not had her recheck, and I hear what you said about.
So a follow-up X-ray is not necessary. What is necessary is an annual physical from your doctor. You're up to date. An annual you're up to date. But what they will look for is distal neurologic changes. The reflexes when they do the hammer on the knee, when they check the ankles or the toes. Distal neurological signs can be a sign of something going on in the neck. Severe would be having incontinence or things like that. But just be often a physical exam, when your pediatrician checks your distal neurological reflexes, that's part of what they're looking for is lanio instability or changes in the neurological status.
So as she's growing as a teenager, it's not necessarily that
she doesn't necessarily need, but if there was something going on, right, then yes, an X-ray or if there was something severe, there's more fancy films, MRIs, and CTs. But yes, your child doesn't necessarily need more X-rays as they get older. to participate. All right, I'm going to stop there. Let me just say, everybody, camera people, LDSS, come to these. The best part of this is not the 25 minutes of stuff I spewed. It's the 10 minutes of discussion here. This is where all the knowledge is. And if you're not here, you're not adding to the knowledge. You're not contributing back. So come, please. Thank you.
Good job.
Thank you, everybody.